So in the second section of the first course of the Ehlers-Danlos syndrome nursing education series, we will cover physical changes in EDS and how these impact the patient. So let's start with some of the common physical issues and also discuss some of the disease manifestations that you might encounter. As we said, connective tissue is the glue that holds the body together. So because EDS affects it, it can cause problems in multiple systems in the body. The symptoms that a patient will experience are according to the subtype. They may experience one or all of the symptoms in that subtype. You may also notice that many symptoms are common to several types of EDS. For example, hypermobility. Many EDS patients also have a wide variety of connective tissue problems. Hypermobility is when a joint extends further than it should. Now, many patients with normal joints train and stretch their joints to be extremely flexible. The difference is with hypermobility, the extension doesn't stop and there's no resistance. So when in fact someone does move their joint, they can actually damage it very easily with repetition of the movement. And these can be sometimes everyday movements. The movement eventually can cause damage in the joint, causing arthritis, pain, and then limited movement in the future. What it does create is eventually it's just a very unstable joint and a painful joint. Some people dislocate joints even with very, very normal everyday movements like walking or pulling a blanket up. EDS sufferers may have mild, moderate, or severe hypermobility, but this will usually be compounded with by other connective tissue problems. Hypermobility causing joint laxity is probably the most prevalent symptom of EDS. In this slide, you may be able to notice that the person's knees are bowed back or hyperextended. She also suffers multiple dislocations of the right ankle medially, resulting in falls, sprains, and fractures of the leg. Her feet are not arched but flat, which is fairly common. And you may not be able to see it clearly, but she has pysogenic pedal-papules, which are small visible bumps on the outer aspects of the feet and heels. This occurs when the connective tissue in the feet does not hold the normal fat that's in everyone's feet in place. This is actually more common in classical EDS, but as mentioned previously, symptoms can overlap. So this person has a lot of pain with walking any distance, and obviously when the ankle decides to pop out of place. Musculoskeletal issues in hypermobile EDS include joint instability and pain. These are directly caused by dislocations, hyperextensions, subluxations, and very loose joints. Also spinal issues like curvatures and disc problems. These will cause pain for the patient. They may cause falls and injury, clumsiness, and general mobility issues. Pain also will then lead to disturbed sleep and possibly brain fog. Skin issues with EDS can include Skin issues with EDS can include loose and stretchy skin, but also very fragile skin, which bruises easily, is prone to tears and bleeding, and poor wound healing. Sutures may not hold, and things like staples or tape may cause reactions to the skin. Some patients have atrophic scarring, and there's one scar in particular called a cigarette paper scar due to the appearance. Long-term complications may include damage to joints, early arthritic changes to the joints, and possibly limited movement, which can be deceiving when diagnosed at a later age. EDS patients may have what is called dysautonomia. This is basically a malfunctioning of the autonomic nervous system. Just a quick review of the nervous system. It is divided into the central, which is the brain and spinal cord, and the peripheral systems. The peripheral system is then divided into the somatic and autonomic system, and it's the autonomic system that malfunctions in EDS. So the autonomic system is divided into the sympathetic, which is the fight or flight system, and the parasympathetic, which is the rest or digest system. So your fight or flight system is something that kicks in when you are, say, running away from a threat, when your heart rate goes up, your blood pressure increases, bronchioles dilate, pupils dilate, your distance vision sharpens, you release glucose, your adrenal glands get stimulated to secrete adrenaline and noradrenaline, your digestive system decreases, so you have less visceral circulation, your salivary glands will decrease to and your salivary glands will decrease to so you might get a dry mouth, and your bladder sphincter may constrict or should constrict because it's not the time to pee. The parasympathetic system is the direct opposite. It's the rest or digest. So you've got increased digestion, pupils constrict, your close vision improves, your salivary and lacrimal glands increase secretion, your bladder sphincter relaxes, and this is what malfunctions in EDS. So you may have a sympathetic response when you don't need one. So it's sort of like calling up the troops for a battle that is not taking place. This can cause a lot of distress to EDS patients. You can have alterations in your baroreceptors as well, and temperature regulation can be affected. Dysautonomia is usually neuropathic in nature, usually from nerve damage. However, in the case of EDS, it's secondary, and it's an overactivity of the system. One common type of dysautonomia is known as POTS, which is postural orthostatic tachycardia syndrome. This can be very debilitating to a patient and occurs when the patient simply stands up. So their heart rate dramatically increases. I believe it's over 40 beats per minute often, and they can have orthostatic changes in the blood pressure. Coping with this syndrome obviously causes a great deal of anxiety for the patient. I'm fairly certain we will have further sections on this important syndrome. Some things that patients experiencing POTS have said that help are things like a seat to always sit down, especially in the shower, cool mist humidifier for overheating, chairs that enabled them to get up quite slowly, simply sitting up for a while before getting up and getting up very slowly, lots of fluids, electrolyte drinks, weighted blankets at times, and possibly a planner for brain fog. The one thing you do not want to do is to raise this person too quickly. Another disorder that nurses should be aware of is something called mast cell activation syndrome, which is a type of mast cell activation disorder. This can include anything from a mild to a moderate to a severe allergic reaction like anaphylaxis that can occur inappropriately. Mast cells are the allergy cells in the body. They then have an allergy antibody called IgG present on the surface of the mast cell that binds to an allergen. This activates chemical mediators and it creates an allergic response. So you may see patients on high doses of antihistamines or H2 receptor blockers like ranitidine. This can be a very serious disorder and deserves its own section, but please be aware of any allergic reactions in EDS patients. They are not to be underestimated. Some very common symptoms that occur secondary to the dysautonomia in EDS are GI symptoms. Some patients experience slowing of the GI tract, difficulty swallowing, constipation, and in severe cases, gastroparesis. Others have the exact opposite. They have hypermotility, nausea, vomiting, diarrhea, IBS, malabsorption issues. Some people will follow what you call an exclusionary diet, or the FODMAP diet is the one that I've used to determine the elimination of things like wheat, dairy, gluten, etc., anything to help control the symptoms. Obviously, this impacts the patients on a daily basis, and when it is severe, it can be life-threatening. Circulatory problems that can occur with EDS are mitral valve prolapse, which can sound like a subtle click rather than a normal lub-dub heart sound. This can also be diagnosed via electrocardiogram. More serious issues occur with valvular EDS, which can involve more than one valve and valvular stenosis. With vascular EDS, they can have organ prolapse or rupture and vessel dissection, including aortic dissection. One of the top complaints of EDS patients is pain. This pain is not only from joint hyperextension and damage, but also they may experience generalized pain due to the muscles trying to hold the joints in place. This obviously can greatly affect sleep, and pain relief is an essential part of an EDS patient's life. Some patients can actually have joint dislocations or subluxations in their sleep, so please provide whatever pillows, etc., that your patient needs to maintain alignment of their joints. Please be aware that patient symptoms, be they from EDS or the accompanying dysautonomia, may be exacerbated by conditions such as dehydration, illness, alcohol, caffeine, and temperature extremes. This is important to nurses because you may see the patient in the hospital or in the community, and that patient, you're seeing them because they're already unwell, so you can expect a more unstable presentation of the patient's symptoms. So to summarize, some of the physical changes you might see in EDS are hypermobility, causing joint instability, injury, pain, sleep disturbance, mobility issues, skin fragility, bruising, bleeding disorders, dysautonomia issues, POTS, mast cell activation syndrome, GI problems causing poor nutrition, cognitive issues and brain fog, and chronic pain and fatigue.